lower limb reconstruction. I was previously at Queen Victoria Hospital in East Grinstead and Brighton, and my most prolific and most sort of biggest accolade so far is that I am co-admin 2 of the Heritage Coast Blue Tits, which is an open water sea swimming group around the world. So hello, and hello from Wales.
Great. We next have David Wallace.
Evening, everyone. I'm David Wallace, consultant plastics at Coventry, leading my limb there, chair of the back press group. I trained to the West Midlands, so exposed to the privilege and the humbling of looking after the soldiers. East Grinstead laws directed me. I've thrown my mind already. Queen Elizabeth, not the Queen Vic. I was a local consultant there, then I was a consultant at Cambridge, and I've been in Coventry for about 5 years now.
Thanks very much. Welcome, David. Next, we have Stephen Lowe.
Hi, Stephen Lowe. I work in Glasgow. I've trained various places around the world, Taiwan, India, Singapore and Holland. I hope everyone's not simultaneously watching the football and watching this.
We can see the reflection in your glasses there, Steve.
Yeah. Thanks.
Brilliant. Welcome, Stephen. And finally, George Wheble. Hello, George.
Hi, everybody. I'm George Wheble. I'm a Royal Air Force plastic surgeon working in North Bristol. And top tip at the moment, I'm already being trolled by the South Wales trauma team. not Loz, I will point out.
Brilliant. So welcome, George. Thank you, everybody, for your time tonight. And I think it's important to note that both Loz and David were huge contributors to the standards for the management of open fractures that were published last year. They're far too humble to mention that.
Also, at the end of the 3 cases, you as the audience will get to vote for the winner of the Golden Nuggets prize. This prestigious prize is for the panellist who's dropped the most wisdom and has been the most entertaining this evening.
So that's the Gold Nuggets prize. So we'll go straight into the first case. Now, the first case was submitted by Dr. Sabari Girish Ambat. I hope I pronounced that correctly. He's a plastic surgeon working at the Apollo First Med Hospital in Chennai in India. And in order for us to determine the order the panel members will present their management plans, we've used a random sequence generator. And for this case, the order is Stephen, David, Loz, and George. So this is the first case. This is a 37-year-old male who was involved in a road traffic accident. He was a motorcyclist and he was hit by a truck. There was a brief period of loss of consciousness. There was a severe crush injury to the anterior anterolateral compartment muscles. The foot was viable. The sole was sensate. There was a single vessel, the posterior tibial artery. Here are the pictures, and your time starts now. So put your thinking caps on, including the audience members. Great. So Stephen, can I get you to, oh, can't see you, sorry. Oh, there you go. Great, your 3 minutes starts now.
Thanks. I'm not sure I've got 3 minutes to talk on this. We've managed a few similar cases in Glasgow. I did work in India, so we did see other cases like this. I mean, just looking at the foot, although they say there's a sort of viable sole with a sensate sole, that X-ray to me is that's a non-salvageable limb. I think this is multi-segmental injury and single vessel leg. My immediate thoughts here are, you know, what we're going to salvage in this patient, just make sure that they're physically okay. If this was an emergent situation, the patient wasn't stable, I'd probably just go straight to an amputation. However, if this is an isolated injury, what I would do in this situation is I would fill it out the foot. And looking at the length of the tibia, you know, I'd probably want about 10 cm or more. And looking at that, you probably just got, I think you'll probably be shy of that once you debride the bone distally. So what I've done in similar situations before is I've taken the foot off as a free flap. But because it's sensate, when I do these fillet transfers, I normally don't divide. One thing I don't do is divide the tibial nerve. So I keep the tibial nerve intact. I will divide the vessels, so the artery and the vein as well, and reanastomose them higher up. I have tried previously to loop these up, but when you loop these up, you find that the vein can kink, and there could be vein damage in amongst all that, so it could be perfused from the artery. So I would take this off as a free flap, and normally what I'd use to elongate the tibia is to flip the calcaneum. So I would divide the calcaneum and put it end on, so the heel is pointing towards the foot end, and the toes are towards the knee, and I'll take the toes off. So that's what I do. In other circumstances where I've had extensive damage, I've had to vein graft the foot onto the knee. There isn't much data published on fillet transfers. The data that's published is mostly on comparing DK with limb preservation. So I would think an amputation for this patient would be the right thing, give him as good outcome as if he tried a complex reconstruction. And I think in this case, I wouldn't call this a salvageable limb. I would go for a fillet type amputation. So that's my 3 minutes. Do I get extra points for finishing early?
No, that's perfect. 2:45. Great. Thank you. Next is David. Oh, sorry. My fault.
Never mind.
Okay.
To me, to you. So the Chuckle Brothers start on the muting. I'm very much in agreement with Stephen. So it does give me the opportunity to go, I concur. I would only just come in with the brief period of loss of consciousness. So back to what we would do normally is you come in through the trauma centre. That's going to be a trauma series. So they're going to have a proper CT top to toe. Just make sure we haven't got anything else. Just as Stephen was saying, if it was an isolator or is it not. From what was not said but implied, we'd have a quick chat with orthopedics and vascular. And the three of us together, I suspect, would come up with exactly the same as Stephen. Is this truly salvageable? If it's not salvageable, if it's salvageable or the patient is insisting on, don't you take my leg, which means just think for a moment, am I doing the operation for them or to them? It might be worth doing sacrificial debridement. That term was taught to me by Ian Pallister, the clever ortho in Wales. So don't design your amputation immediately, but just debride. We've got a multiplanar, circumferential, degloving, multi-segment fracture. So you could justify serial debridement till you've got a stable wound. And it may be for this individual that they'll be accepting a stable post. How the hell are we going to get a stable post? Well, that's likely to be a frame. So have they got the social capital and the support to deal with a frame? And it's probably going to be about a 2-year recovery if we're lucky. And if you haven't got that, then I think it's highly likely that we're talking about Stephen's scenario. I completely agree. I have found the wrapping around of the vessels highly unrewarding, even if you're making the curve incredibly long. So unless we're talking about a fillet of sole that's moving about that far, so you can have a single curve, you're usually better off considering reanastomosing. Of course, you're going to keep the nerve in continuity, so you keep the sensation. Because if you think about it, those vessels are straight through the zone of trauma, and it's highly likely they'll have an occult DVT. So if we look, Alex Crick and the clever gang at Salisbury have done some nice work on that. And I think they had a 23% occult DVT rate, which supports why Stephen's saying I would anastomose it, but keep the nerve intact. And that can be highly effective. So I would be going with Stephen's below knee, as a two-stage procedure. I would still do a sacrificial debridement, so I'm effectively decontaminating, getting the wound from dirty to clean contaminated, well, probably contaminated, and then at the second stage, a definitive reconstruction.
Great. 2 minutes, 52 seconds. Very good timing. Lars.
So I would go between the two, David and Stephen, and I wouldn't take this leg off immediately. I would, again, as we know, in terms of principles, go through the resuscitation phase. They come into the major trauma centre, and then a term that Prof Pallister and the team at Wales use, and obviously throughout the world, is a damage control scenario. So we're looking at a damage control scenario, potentially in an isolated limb if we've excluded everything else. So these act quite like blast injuries, I think, in terms of that sort of degree of soft tissue and bone. I didn't actually see the whole X-ray actually because I think my face was in the way, but I could see it was multi-segmental. But also we didn't get an X-ray of the foot. And I saw there were two injuries anterior to the ankle and in the midfoot on the dorsum. So the likelihood is that we've got multiple fractures at that level too. So we would, or certainly I would, with my orthopaedic colleagues, we would probably put an X-fix on, we would radically debride, and that may well include shortening. But we would try and not do that in the first stage because, you know, there is evidence to show that obviously, you know, being able to wake up to be counselled through having an amputation is gives better outcomes. So so damage control, radically debride with our orthopaedic colleagues who will be debriding bone as well. And you know, we have to consider the amount of bone that's lost, also the distal part in terms of the foot and the fractures and the soft tissue damage, and then probably a reason, as Stephen and David have said, a reasonable discussion about how we would potentially shorten this definitively. Thank you.
Great. So that was 1 minute 42 seconds. Ooh. Brilliant.
It's easier when people have gone ahead, though.
True. So next is George Wheble. Just before you start, George, just to say to the audience members, if you have any thoughts or questions, please jot them down in the chat box and we'll come to them in the round table discussion. So George, your 3 minutes starts now.
Excellent. I was rather hoping my 3 minutes might have started whilst as soon as Loz finished. I think I might be able to beat her. I think a lot of what's been said already is absolutely bang on. I'm inclined to agree with Loz about not taking the leg off immediately. I think for me, particularly, you know, with my military hat on, the key to good outcomes in these kind of cases is the adequacy of the first wound excision. And we know certainly from a lot of the work that we've had militarily from the last 10, 20 years, particularly in these really nasty type 4 multiplanar degloving injuries, you get all sorts of contaminant blasted up between the fascial layers, between the muscles, and you're probably going to get about 90% of the contaminant out of the first go. If you then aim for getting 90% out of the second go, you're still leaving some of it in there. And I think there's a real case for, as Loz has mentioned, serial wound excisions. See if you can wake the patient up and see what you're left with. And then often, you know, the decision is pretty straightforward to make. I quite like Stephen's idea of filleting the foot and using the calc bone, because I think he's absolutely bang on there. You're probably going to be a wee bit short for a standard below knee prosthetic with what tibia's left. And I quite agree. Trying to get the loops in, leaving them attached, is nigh on impossible. The one thing that I think hasn't been mentioned that I'd probably consider would be if the saphenous veins there, using that as a loop. It's often protected in these kind of injuries, and it can then potentially make your micro easier then, because you can put it wherever you want.
Great. So 2 minutes. I think Lars won that one in terms of brevity. It would be great to get some discussion going. We have a question from Nick Brinkman. What is the advantage of having glabrous sensate skin on your below knee stump instead of a conventional stump? Who would like to have a go at that? David.
It doesn't matter about the glabrous, it's your brain. You're walking on what your brain intends you to walk on. That's the key part. There's also incredibly hard wearing. So it's skin that can tolerate weight bearing for a long time. So it's not so much the glabrous nature of the keratin layer, it's all the structures that hold it on. I'm sure the rest of us, I haven't found out whether fascicutaneous or muscle is best to resurface a weight bearing surface. And it's the debate that goes round and round, and you can either find someone who's definitely found the answer, or everyone who just goes, well, it depends. If you can put something on that you normally find we've evolved or designed to weight bear on, that fat pad doesn't quite get it. It's a you've got a superficial fascial system that is in 3 dimensions holding all the fat bits in. So it doesn't go anywhere. So I've even now done, under direction from the rehab guys, I've done Symes amputations where we hold on an insensate heel pad onto a diabetic leg, which is more durable than a poorly sensate or even normal sensation below knee, because that skin is highly adaptive for weight bearing.
Thank you. Loss, you wanted to jump in there, I could see.
No, I was just agreeing that actually the fibrous network, you know, the plantar network is key, isn't it? Because as David says, the reconstruction of the sole or the heel is one of those real dilemmas. You know, do you use the muscle and then you've got a skin graft that's going to keep ulcerating? Do you use your ALT or your fascicutaneous where you've got a floppy bit that moves? So yeah, I would agree.
Question from Omar Dawood. Do you do TMR if you can for primary amputation in such trauma cases? David.
Yes, I will do, because when I asked Jason Sousa, the nice guy from America, when he kindly came to the Bournemouth meeting, he said, get on with it. So I did. So I still find it tricky, and I think it'll be interesting to see the data coming out with that. It's easier to do it primarily because, like with all things, it's getting it right first time. So it's good for the patient, but I'm not keen on going around the back of the knee straight away. So I will do it through the normal amputation stump, residual limb. So you can find numerous homes for the common perineal. It's a little bit trickier on the Solea side. I was having a nice chat with James Baden, one of my lovely colleagues at Birmingham. And when we're talking about finding a decent home on Soleus, it's a little bit harder for the posterior tibial. But that's my preference that I would do it. It's now my default for the last year or two.
George, you wanted to jump in.
Yeah, I'm very much in agreement with David on this. I think one of the sensory nerves are the poor cousins in any trashed limb, particularly in the context of an amputation. And we get quite good at managing the big nerves, but certainly my experience prior to working in Bristol was in Salisbury, working with Alex Crick, and she's done around about 200 military revision amputations, and consistently the saphenous nerve and the perineals, the tibial nerve we get pretty good at, and the sural generally seems to not cause that many problems, but they're not terribly well managed in the context of a traumatic amputation, which is often an atypical level with an atypical skin envelope, as opposed to your standard like diabetic or vascular amputations. And I think Jason Sousa is I think he's really leading the world with his TMR, and the general principle of giving the nerve somewhere to go and something to do. It seems to make sense, and certainly in my experience, which is not massive with these cases, but certainly my experience is that it does make for a better stump.
Great, thank you, George. Just one final comment from the floor from Sultan Alamri. If the fractures are all extra-articular, then they can all be fixed, no matter how much time and complicated course they need. Stephen, have you got a response to that?
Yeah, that's not really true. I mean, yeah, of course you can try and fix anything, but sometimes you get these reconstructive cripples. You have to assess your health system. Is this patient going to have an X-fix on? I mean, we've had patients come from Europe to our unit, and they've had X-fixes on 3-4 years for things which they should have had an amputation for. So that's not necessarily true. You have to address your patient and your healthcare system. And in that patient that we've seen in India, I think that patient would be in the frame for years, have complications. I wouldn't even start on the reconstructive route for them. So be judicious. You look at the data from the LEAP study. Amputation gives us good outcomes at 5 years as reconstruction, psychologically and physically. So don't create reconstructive cripples. Just because you think it's going to salvage a limb.
David, let me hold you for 1 second because George wanted to jump in. Just final minute, guys.
Yeah, I won't take all the time, promise. So, I think the comment that they're all extra articulate, you can fix them, and certainly we've got some slightly different thinking orthopods here in Bristol who are quite keen to put dead bone back in, little mini plates and nails. I think I agree with what Stephen says in this. Like, technically you could, but it'd be a technical success over a common sense failure.
Very, very good. That's a good phrase. But it's George. I like that phrase that went with it. Like when we were talking about Ian Palliser's sacrificial debridement rather than a below knee, take away the dead stuff. But here, when Stephen talks about a reconstructive cripple, so there is, if you go to the literature, you can find it's all the Ds. You can end up with a technical triumph. You've got a lovely X-ray. You've even got a healed wound with a great LD covering that limb. But they're divorced, demoralized, destitute, drug addicted, on the toll and depressed. And there's probably another D you can get in there. But the photo's really good for the presentation. So I'd be really wary. And as Stephen's just mentioned the LEAP study, what are the factors that they need? They need self-efficacy. The Americans in England will call it get up and go. What's the patient's social capital? So in the States, it's, are you insured and are you college educated? It's very similar here. The more social capital you've got, the more backup you've got, the more you can invest in your reconstruction with the team. And I completely support Loz. We want to do the amputation for them, not to them. So you do it as a sequence to get with them, but do it with them, not the X-ray.
Okay, we're going to stop that discussion there. Fascinating.
We just have one more question from one of the audience about the Kapana technique. Does the panel have any views or experience on this?
Can I answer on this? So Kapana technique is used rarely, more for femoral bones in a trauma situation. I do a lot of tumor, so most of my work now is sarcoma and tumor. So we do use Kapana technique when we take the tumor out, we irradiate it and we put the fibula back in. I don't see a role for Kapana in this patient, I think possibly high Venkat Trami might go for a long fibula in that case, but I'm not sure anyone else would. He's very skilled. So I think the Kapana is less useful in a trauma situation, more for tumor work.
Lovely, thank you very much. So I tried getting Dr. Ambat on. Unfortunately, he's not on the line tonight. So this is what happened to the patient. He had the first debridement and an IM nailing on the date of the injury. And then post-op day 2, he had a second debridement. Then they did an AV loop and a free ALT. At 7 months, he had a free fibula for a bony non-union. A year and a half down the line, another bone grafting for a persistent non-union at the upper end of the tibia, and at 2 years we got onto full union. What we are missing from that is, as everyone says in the panel, his function, his quality of life, etc. So that it'll be fascinating to see how patients like this do down the line. Okay, so let's go on to the next case.
So this case has been submitted by Robert Ditchman. Again, I hope that I've got the pronunciation right, from the Netherlands. He's a plastic surgery registrar at Erasmus. and he is presenting on behalf of Dr. Udendorp. So here is the case.
Oh, hang on.
Yeah, the order. So from our random number generator, we will now go in this order: David, Steve, George, and last of all, Loz. So this is a 53-year-old man, had an injury sustained from a forklift, left lower limb. It was trapped for a short period of time, and he presented with a burst laceration above the medial malleolus. He had a cold, pale, pulseless foot with a sensate sole. He had a Mason nerve fracture, that's at the proximal part of the fibula, and disruption of the anterior tibial artery at that level. He also had a distal fibular fracture with disruption of the perineal artery, and the posterior tibial artery was dissected distal to the medial malleolus fracture. This is also a CT, so it just gives you an idea of the levels of the arterial injuries, which are pointed by the arrow. So that is the level of the damage of all three vessels. This patient had a fasciotomy, but we don't want to say too much. Okay, so are you all ready? Time started.
And again, here's the order. I'll stop sharing the screen.
Okay.
So we've got a nice pulseless limb. So
David,
we'll
you
use
first.
the new national guidance on the pulseless limb. So there's a really nice one on from BOA, back press and vascular, and ideally try and get all three consultants together. You've got the CT angio, and we'll get in there. Now, I'm not entirely certain what a short period is, but we've got to go back to that nice article that Graham Glass and the gang did with the World Literature Review. Basically, if we haven't got blood into something by 6 hours, it's not going to be useful. So how long have they been trapped for? I would recommend that we're going to be talking about a shunt. I'd be surprised if we're going to get realignment and flow. We've obviously got a nice CT angio. Forklifts are beasts. They've got a lot of momentum in them. So you may think, oh, it's not very fast, but remember, it's got about isn't it 1.5 tons, 2 tons inside that little bit down at the bottom. So you can have something lifted way up there and it doesn't tip over. So it is for someone of my age. When you had the adverts when you didn't do your safety belt up in the back of the car, then as you come through the car, you're an elephant going. Hurr! It's momentum. So you've got a multiplanar circumferential degloving again, shunt, fasciotomized, damage control, come back to fight another day.
Great, 1.5 minutes. So next is Stephen. The time starts now.
So I spent some time in Erasmus Centre in Holland. It's a great place. I'm pretty sure this is something that Toon Lusterborg would be doing a immediate free flap for. I have maybe a slightly different approach. I'm pretty sure that's what they've done in Erasmus, immediate free flap. I would probably go for immediate free flap as well, and that's what I've done in 3C injuries similar to this. I know there's the guidance from to use shunts and things like that. Actually, I don't. If the time limit's within a reasonable time limit, you're quick enough raising a flap as a consultant and doing an anastomosis. That's what I'd normally do. There is some work coming out which is quite interesting about ECMO and infusion. There's some work from a group in Germany which finds that if you just infuse saline without not ECMO or anything, just infuse saline, it's got enough dissolved oxygen in it to perfuse a part, and we've started using that in tumor cases when you've got to amputate. So you just hang a bag of saline. So that's just something slightly off topic, but to think about. and that might be something to be done in the future for amputates with 3Cs. What I would do, what Toon probably has done here is a free ALT flow through flap. And probably you can do that quickly within the time limits, so, well within the time limits, even if it's a few hours to get them on table. What Dave has said about Graham Glass's study and all the stuff from Boast, that's totally right. But there's a little bit of personal preference about here. I would probably go for an immediate free flap rather than shunt and do vessel. And I normally wouldn't get the vascular guys involved. Below the knee, we would do the surgery. We'd phone them up out of courtesy and just say, like, we're happy doing this. But I would always prefer doing anything below the knee. We should do anything below the shoulder. We should be doing that. That's it. Thanks.
Lovely. 2 minutes on the dot. George.
So I'm more in the Wallace camp here. I think I've been bitten several times with aggressively trying to reconstruct patients, and perhaps I'm just not as good a judge of where that damaged tissue is. But I think I would, in the first instance, you need to restore vascular inflow, and I think a shunt is a really reasonable way to do that. Fasciotomies and a really kind of accurate wound excision are what you need here. My reasons for not doing an immediate free flap are that I think it's a lot to do to get absolutely everything spot on and right, and one thing wrong could compromise the whole case, whereas you don't lose anything by revascularizing with a shunt, doing some fasciotomies, coming back to fight. Often these things happen late at night or whatever. You come back the next day and you've got to expedite these. You've got to get them covered. But then sort of in the cold light of day with a little time to think, and I always do better. I know that I do better with an hour or two to think about stuff rather than, snap my fingers and off we go. The other thing that I'd say from a reconstruction point of view, I'd probably, again, I think, Stephen is more experienced than I am in these flow through flaps, particularly in the context of trauma. I find really difficult to get all the bits in exactly the right place. Maybe I'm picking the wrong patients, but what I would probably do is do vein graft reconstruction of the posterior tibial artery, and then plan my free flap to go on more proximal to that onto out of the zone of trauma. I think it'd be easy enough. The zone of trauma is going to be everything's going to be opened up, and I think it's one more anastomosis, that's all, or two more anastomoses. But for me, it makes it a bit more bulletproof, because I've been caught a couple of times with trying to put flow through flaps in and then compromising in either the positioning of the skin paddle or the positioning of the pedicle.
Great. 2 minutes 15. Thank you, George. Lars, whose camp are you in?
I'm between everyone. So I think, so a couple of things. So I would agree that actually I wouldn't get vascular involved, because not that I don't love my vascular colleagues, but actually they look to us to do the reconstruction at this level. These are small vessels. I mean, I was in a reconstructive procedure with a small child in the upper arm, and my colleague was, sort of having a little bit of a hissy fit around the brachial artery. So it does depend on how experienced you are, and we are experienced microsurgeons. So that's number one. Number two, I wouldn't do a free flap straight away. I am very much, I'm not a serial debrider. I think we've moved away from that. We don't bring the patient back, nibble a bit, bring the patient back, but we do radical, adequate debridement. But there is that thought of actually, again, as George said, a thinking period of assessing. I'm not really clear in terms of the injury levels, to be fair, because we've got a burst laceration with a skin defect, significant defect in the medial mal. That's where our posterior tibial has gone. Then we've got the isolated at the anterior tib. So, I mean, obviously there was no DP to feel, and then you've got your perineal. So I'm wondering where I would shunt, but I would obviously need to be exploring all of those areas and fasciotomizing, as we've all done. But I think I would, again, it's damage control, it's getting in there with your orthopedic colleagues. It's actually, I would shunt, and then I would also look to see what the level of damage is to reconstruct. And again, you know, from the orthopedic point of view, that's a 2-level segment. Again, I wasn't sure about the medial mal in terms of disruption below that. Would that need some stabilization? Have the ligaments gone? That's a discussion with our orthopedic colleagues, and we're really blessed to work with great colleagues. But those are my kind of thoughts in terms of how I'd proceed.
Great, brilliant. Rebecca.
So,
that was 2 minutes, Loss.
yeah, you're well within the timeline. Is Robert Ditchman here to reveal what was actually done? Or?
Yes, he is. He's waiting, and I will promote him to join the table. Robert. Oh, yes. Hello. Welcome. Calling in from Erasmus.
Just from home. Good evening, Steve. Good evening, everybody. Thanks for having me, and thanks to the panel for the expert opinion on the case. I'm sorry I didn't provide a better picture of the soft tissue injury. It was difficult getting it after a while. So I think everything you said was very much considered. I don't know if you know the Dutch situation, but we have a third party to the vascular plastics marriage. They're called trauma surgeons. They control the emergency department, and they basically call us into the case. And what happened is they did the trauma survey, and then they took the patient to the operating theater, did the fasciotomies, did the external fixator, and they did ask their vascular colleagues to perform a PTA of an angioplasty of the posterior tibial, and they managed to get it open. So then they had one vessel that vascularized the foot. They weren't really sure whether the leg was viable, so there was some delay in asking us to come in for coverage and do the final fixation. Obviously, because of the crush injury from the forklift, we didn't dare to use anything local, and although we did feel dorsalis pedis pulsations and then Doppler sounds in the operating theater, we weren't sure whether this would be on collateral flow or just a distal anastomosis, so we wouldn't want to sacrifice any more vasculature to the foot. So we ended up doing a venous loop between the descending genicular and the distal stump of the large saphenous vein, which was actually injured during the fasciotomies. And then we took actually a very long ALT flap just to be able to get the pedicle superiorly enough and covered the entire medial aspect of the foot. And the lateral bit could be closed primarily for the main part. And we just put a small skin graft over the muscle of the lateral compartment. That's it.
Great. Thank you, Robert. I could see, Stephen, you had clearly thoughts going through. Go ahead. Share with us.
Who did the case?
It was Misha Zuidendorp, which is basically Teun's right hand. So she's a Teun adept, just like you are.
Is that what Teun said he would do as well?
I think so. Yeah. Yeah,
So
they discussed it extensively. Yeah.
I've never used a saphenous loop. I would probably have put a flow through free flap and that. But you're right about the trauma surgeons. The situation in Holland is slightly odd. You've got a world-class plastics unit on site, and you've got a trauma guy coming in, sometimes doing some weird hand surgery. I remember, some really bad hand surgery done there by trauma surgeons when you've got world-class hand surgeons in Erasmus, and that's odd as well. Once they get the trauma team in, you're already pushed down a slightly different course from if you'd come into that theatre straight away. If Teun had come into that theatre straight away, I'm pretty sure you'd have done an immediate flow through flap, not pit PTA and all this stuff. So it's a slightly, your management is biased by what the trauma guys do, and I think that's one disadvantage of that kind of setup.
David. Oh, sorry, Rebecca.
I was just going to ask Robert what he thought about that comment. Is that a fair comment?
It is a fair comment. Well. To be honest, so the trauma guys really jump into the vacuum basically left by the orthopedics. So the orthopedics departments in the Netherlands, they tend to be less interested in trauma and do a bit more of the elective cases. A lot of osteoarthritis going on. And the general surgeons, they have a very powerful position in any Dutch hospital. So they basically control the emergency department, and we depend on them to ask them into the surgery. We often get called very late into the case. If I could guess, then they call us 10% of the time when the patient's in the emergency department. Then 40% of the time would be when they've already operated on the patient and they ask us into the theater to fix it then and there. And then the other 50% of the time would be, hey, listen, we had this case a couple of days ago. Would you come and take a look?
Fair enough. That's hard. But that's one of the reasons why I would get everyone involved, because it's an ongoing educational thing. We all know we're right because we're plastic surgeons. So we could do like Steve and Loz, but what I've done in the past is I've actually got my vascular consultant friend. There's no point having to play with some well-intentioned vascular registrars. It's about how you're building your team for the next 10 to 20 years. Yeah. How you're sharing your knowledge with them so they know what you can do. Yeah. And that's a really slow thing, and you have to tell them all the same thing time and again. But I've done a brachial artery repair. I did one end, my vascular consultant colleague did the other end. When I was doing the hand salvage, of course I wanted to just get on with it, but I let the vascular consultant do one of the arteries, because then we're doing it as a team. And the next time we're going to, again, do it together, because it means we always get called, and you therefore have the consultant orthoplastic vascular discussion at minute 15 to 30 after the referral from ED. Because you all want to call each other. I look up stuff called like Chris Turner, consultant at Coventry, lovely guy. It's civility saves lives. It's going into that milieu of leadership, teamwork, and other things.
Yeah, I think that's a great comment. We do have actually a good lower limb outpatient clinic going with Teun Luisterburgers in it, and the trauma surgeons and orthopedics are all in it. They manage difficult cases together, but just these collaborations, they go a bit up and down with their leniency.
The idea is to get the collaboration the same at 2 a.m. as 2 p.m.
Exactly.
Good luck.
There's a lack of time, so just last couple of minutes, I can see George and Loz wanted to say share views.
Yeah, thanks, James. So, Robert, that's a really interesting case. I just had a question. Just to push back to you, how did you find the anterior and the lateral compartments in the longer term? Did you have any problems with the anterior tibial injury? Because you mentioned there was anterior tibial and peroneal injury.
Yeah, they were. So we didn't actually explore to look for the vessels. We thought, well, the peroneal vessel was clearly in the zone of injury. It was ligated by the general surgeons. Just getting it to get an anastomosis, you need to either get it around the fibula, which was just bladed by the trauma surgeons, or through the membrane, and then it's crushed between all sorts of muscles. So we didn't go for that.
I mean, I've had a few cases where you think they're all right, and then you just get this slow death of muscles, particularly in the anterior compartment, and that causes more hassle than it's worth. And I mean, I guess I put to the rest of the panel, would you consider reconstructing the anterior tibial in this instance as well? Obviously, if you're going to dive on in and do everything in the first go, that's quite a big ask. But would the rest of you consider that as part of your planning process in the when in the cold light of day when you're going for your definitive recon?
Loz?
I wouldn't actually, I must admit, in terms of how Robert has described. I think, again, opening up compartments, obviously they've all been open for decompression, but I think it's quite a tricky thing. I always find the anterior tibial is really tricky anyway because it's so deep, but I wouldn't.
especially at that level, you know, it's going to be a right royal hassle trying to get to them. But just wondered how you'd found them.
How easy is it to get it there? But we all also know the more vessels you repair, the better off you are. We know we've got the evidence on that is open to interpretation, and you've got that one from 30 years ago from Thailand. And you know, if you repair all the vessels, your bone heals much more quickly, almost half the time. And you've got the nice case series from the States, you know, where they've got about 1,000 in them, and you've just got that straight line between 3, 2, 1 vessels. So if you can, but at the same time, we've said it before, haven't we? Just because you can, should you? And that's plastics, isn't it? But there's always something we can do. What should you do? I would take a judicious call. If it's a feasible repair without making it over complex, it's not going to add more than, off the top of my head, 2 hours, and it's likely to work, then I'm going to be going, I'd rather reconstruct it. And I'll be talking about a flow through, just as Stephen was suggesting. It's not my idea, it was Stephen's idea about putting a flow through of an ALT or something similar. So I'm not going to take credit for Stephen's idea. That's not fair.
Great discussion. We need to move along. I'm going to just pose one more question that has been asked to Stephen from Nick Marsden. If this is a crush type injury, how aggressive do you debride? If you're going for an immediate recon with a flow through, are your orthopods equally as quick fixing the fractures as you are raising the flap?
So yeah, crush injury, take out as much as possible. You know, most of my work is now, I do less trauma now, I do more tumor work, and pretty happy taking big chunks of muscle out. There are ways to reconstruct. My other interest is functional reconstructions. There's ways to reconstruct lower limb, quads, etc. Are the orthopedic surgeons quick? There's a discussion there to be had. They can be quick or they can be slow, and in certain circumstances like this, you just want some degree of damage control and stabilization. So it might just be an X fix, come back another day. And that's what we've done in these kind of urgent situations. A couple of pins, stabilize the limb, and they may decide to do something another day. There's another technique that I've used in 3C limb, which is to loop the anterior tibial onto the posterior tibial and put the free flap onto the posterior tibial. I've only done that once, but it's just something to be aware of. Sometimes you can get a double level injury, which are two different levels. So you can loop one vessel onto the other, put the free flap onto the shorter end of the artery.
Thank you very much. Right, it's time to move on to our last case.
Yeah, so this is a shorter case, I think. Can you see that?
Yeah.
Right, so this case is from Colombia. So Laura and Naya will be presenting on behalf of David Fernando Ropero, plastic surgeon from Bogota in Colombia. And the order this time will be Los, George, David, and Stephen. So this is a 45-year-old man presenting with a 6x3 centimeter mass over the anterolateral knee, and it was a 6-month history. The histology showed a high-grade fusocellular sarcoma. It was a grade 2 T1N0M0 stage 2 disease. They went in for a wide local excision with 2 centimeter margins. They took the tibial anterior tuberosity periosteum, the lateral portion of the patellar tendon paratenon, and on the other side, the external femoral condyle periosteum was taken, the articular capsule and the collateral ligament were preserved. So the question is, how would you reconstruct this wound? So your time starts now. Brilliant. So, Los, your 3 minutes starts now.
Okay, so I'm well out of my comfort zone here because I do not do sarcoma and I haven't done it for many years. So I'm going to apologise to Stephen Lowe and to my team in South Wales, okay? So
imagine it's a trauma defect, Los.
So listen, we are dealing with, as you say, composite issue with regards to the skin, soft tissue, and the anterolateral portion of the knee. This is the mechanism of the knee, so obviously I'll be working with my orthopedic surgeons as well. I'm assuming, but you shouldn't assume, but we would be wanting clear margins, which I can't remember whether they were or not, and then we want to reconstruct. So effectively, I would probably be looking at an ALT. I'm looking at the potential for a collateral ligament, so I'm thinking the iliotibial fascia in order to potentially use that as a reconstructive option, and that's probably my limit of expertise. So I shall bow out now.
1 minute. George.
Am I allowed to just say ditto?
You can, but you're less likely to win the Golden Nuggets prize.
I've got to say, I concur.
Oh, damn it. There's that competitive element to it. Yeah, I'm with Loz on this. I think having this as a combined case with an orthopedic surgeon who's confident with what needs reconstructing in the knee and what you don't, I think that's the really critical thing to this, because it's all well and good resurfacing, but if you've got an unstable knee, they're not going to necessarily thank you for that. So I think the things for me are, it sounds like you probably don't need to reconstruct the patella tendon if there's some of it intact, but probably do need to reconstruct the medial collateral. I'd be very much led by my orthopedic colleagues on what they want to do regarding that. Probably bone, tendon, bone is what our guys here would do, and then my choice of reconstruction would be dependent on body habitus. That looks eminently ALT sized and plumbed onto the superior medial geniculars and the great SAF, I would say.
Just over 1 minute. David.
I concur. No, it's a really good, simple way of doing it. You've gone for a reliable workhorse flap. What's wrong with that? Check we've got clear margins. I would then be talking about what do we need to reconstruct to help on that. So it'll be a discussion with orthopedics. So just as George said, how much of the patella tendon is still there? Have we gone past, as it were, in my mind, I call it the equator? Is it going to ride away, or is it going to be all right there? I'm more inclined to go with Loz's suggestion would be taking a bit more, but why not? You're there on the ALT, take a bit more fascia, and then MITEC it, weave it in at the other end. My top tip on the MITECs is make sure the person who's doing the list the next day hasn't ordered all the MITECs in that you've just used to do the reconstruction, as I did to Ian Grant when I was in Cambridge when I did my foot trauma case. I wasn't available to hear the Wallace from 200 yards away, but that's a different scenario. So I probably would be MITECing a couple of fascial bands across to attempt to restore the anatomy, but also remember you're doing it as dynamic, and the knee surgeon is going to place them better than us because they have a much better understanding of where the fascia moves dynamically, or the patella true tendon and the accessory collateral things. I'm also quite tempted to think if we've got clear margins, could do a nice keystone, because you'll be into, if you're releasing round at the midline, you could drape that across. It'd be quite, and then you'd have to brace the chappie out straight for a few weeks. And if you've got a highly compliant patient who doesn't want to go through the extra palaver of a free flap, that's an option, but I would prefer to do a free flap. It's going to be more reliable, and you can plumb it in either end, either up onto the distal thigh, or you can probably do the swanky scenario. You can even actually cut anterior tibial further down and bring him up so you've actually got him available just there, because it'll be a long way down to go and get the posterior tibial.
2 minutes 10. Excellent. So last of all, Stephen.
So we get this kind of defect quite frequently in sarcoma. There's a few things to consider. So this patient, you know, obviously you need your clear margins, but we always reconstruct straight away. A lot of these patients with the higher grade tumors will need radiotherapy. So there's evidence to suggest that when you have certain types of flaps, especially skin flaps, they're more robust against radiotherapy, reduce your wound complication rate. And then patella reconstruction. Now, you don't actually need to reconstruct the patella here because most of it's intact, but you have to think about reconstructing the knee capsule and the tracking of the patella. So probably you want something on that side of the leg to stabilize the patella. It doesn't need to be reconstructed, but it needs to be stabilized. And I think in the summary, they said the collateral ligament was intact. If it wasn't, then you can do some forms of hamstring transfers, etc. Then you consider whether the patient's fit or not fit for surgery. But what I would normally do in this situation is that I do a gastroc MSAP. So I do a combination flap, and I tend to do this for all complex knee defects. Hopefully we've got a paper coming out soon on this. We've got about 30, 35 cases on that. So we use the gastroc fascia to reconstruct, and that can be partial or total tendon. And then we use the MSAP separately, and we can orient it towards the wounds. The muscle goes in one direction, often transverse, and then the skin flap can go in another direction. For the bigger defects where you've got patella missing completely or kneecap missing as well, what we use is the cadaveric allograft. So you can actually buy the tibia, patella tendon, quadriceps tendon. We use that to reconstruct, and then I use MSAP gastroc on top of that. I suspect what they've done in Colombia for this case is that they'll have done something like an ALT with fascia lata, because that's interesting. That's probably not what I would do, because gastric MSAP works really, really well. It's a fantastic flap for these types of complex knee defects.
Can I just clarify, your gastric MSAP is done as a pedicled or a free?
No, it's pedicled, yeah. It works great, and because you're taking volume out of the calf, most of the time, but not all the time, you can close the wound primarily.
Right.
But it's a fantastic flap.
So they're spatially independent, your muscle component and your skin component.
Yeah. So often when you've got a complex knee defect, you want to do a transverse capsule reconstruction. So the muscle goes in transverse, but then your knee surgeon's done a vertical defect. So dig out the MSAP and it goes in vertically. So you orient it in two different directions. I started doing these in 2012. And then Jeffrey Halleck published it, I think the year later, so I never published it at the time. And then Marco Innocenti wrote another paper saying he described it, and Jeffrey Halleck described it many years before. There's some other papers since, but no, it's a really good flap.
How much do you dissect out your MSAP in that?
You don't need to dissect it out much, so not enough to get your orientation, or if you need to adjust it in plane, which you don't really have to do often, then you can dig it out more. Also, you can have it on two pedicles, you can split it. So sometimes you've got one bit that goes vertical, and because you want to decompress where your muscle comes in, it's sometimes bulky, you can use the other flap as a triangle to decompress that inset. So very useful for complex knees. I know Henk and the guys down in Oxford have run big series on just gastric only. In Glasgow, we don't see these small defects which are sufficient for gastric. All our defects are terrible, and that's really helped with salvage for these cases.
Great, thank you. Look, before we get on too far, we've got David dialing in from Colombia.
Super.
Oh, hello.
Well, good evening to everybody. I'm Laura Naya, Dr. David resident, and I'm going to speak in behalf of him. Well, good evening.
Do you want to share? You had some slides to share. Is that right?
Yeah. Well, we're going to change. We are going to share our screen. So wait a minute. Okay. Is it already there?
Not yet.
Here says that the host has enabled the function to share the screen.
Oh, right. Okay, give me a second. Okay. Yep, there you go. You should be able to do that now.
Yes.
Okay. So this is a little explanation of how we designed and created our reconstruction from this defect. Yeah, sorry. Yeah. Here. So this was the defect that was approximately 10 times 7 centimeters in diameter. What we first did was that we identified the perforators from the fibular artery. Then we designed a keystone flap here. The dimensions were based approximately 1.5 or 2 times the diameter of the defect. And the design of the keystone flap included the fibular artery perforators that were here. We identified them with a Doppler, with a hand Doppler. Then we made the dissection. It was in a subfacial plane. And once we have the entire dissected flap, we made a rotation towards the right-handed rotation and an advancement in the upward direction, as you see here. The result was this here. And on the posterior aspect of our flap, we made a VY closure, which you can see here. As Dr. Stephen mentioned, the structures of the knee were preserved, so it wasn't a complex knee reconstruction from like the tendon and the paratendon. They were intact. So the orthopedic surgeon said that the function was preserved and that the defect could be immediately reconstructed. This is the picture. Postoperative. And that's all. Thank you.
Great, thank you very much. So, David, you mentioned the keystone flap in your soliloquy. Can you is that how you would have designed it?
It's going to be a pinch test, isn't it? Just as you kind of suggesting with your VY supine, always be slightly wary how much you're going to be able to recruit from the medial thigh, because it's like that little deceptive bit there. There's actually a little zone of adherence when you go along as you go from the front to the posterior aspect. So it's going to, you've got a young person, how much skin have you got? But you know, it's going with something that's got to be reliable. Because you're going to thinking of the radiotherapy afterwards, just as Stephen was pointing out.
I mean, David's solution clearly works very well, covered the defect. I wondered whether any of the panelists had any comments about local versus free reconstructive options here.
I really like the reconstructive option in terms of the gastroc MSAP. But I must admit, in terms of my dissection of an MSAT, which haven't been very many of them, I normally end up rogering the gastroc. So it's nice to know your little tip, Steve, about how you kind of, you know, you have to wedge it and how you dissect and separate. Because I think that's a really lovely technical tip. You know, again, it's one of the things I'm always concerned about MSAPs in our acute recon for trauma, primarily because you go to the other good leg and then you take it, and then even if you can close it directly, you know, I've had a 30% complication rate where I've worked previously because they've fallen apart. So
I wonder if I can go back to David Fernando, if the collateral ligaments of the knee and the more of the patellar tendon was taken out, would you have done the same, or would you have considered another reconstructive option?
No, we would have done the same.
Okay.
Nice.
Yeah. Okay. We would also have probably added a tendon graft for the reconstruction for the knee structure, but for the soft tissue defect, we would also have made the same reconstructive option with the keystone flap.
Great.
What would you have used for a tendon graft? Steve mentioned allograft. Would you use a cadaveric allograft or?
Probably fasciolata.
Thank you.
Great. Any final thoughts before we move on? Well, thank you very much, David and Laura, for dialing in all the way from Colombia. Fantastic to have you on.
Thank you very much.
Cheers, guys. So let me just get you to, yep, that's great. Now, so we've discussed our 3 cases, and there are just a couple more things to do, which will be fun. Here we go. we have an anagram in true countdown style. So get your pens ready. Everybody has 30 seconds, including the audience, to come up with the answer to this. I don't know what the prize will be, but it will be, I don't know.
Brilliant.
Kudos and glory and all that kind of stuff. 30 seconds starting now.
Put it on the chat if you get it.
David, can you do the music? I'll tell you in 10 minutes, 10 seconds.
But it's, yeah, but no, because everyone's already put it on.
Yeah, we would like to say a big thank you to everyone. Thanks to our case submitters. Thank you to our panelists, and thank you very much for our audience. It's been a wonderful evening tonight. We do need to do our golden nuggets vote as well.
So has anyone got the answer?
I think we've got multiple winners on the chat here.
Have we?
Yeah.
Oh, wow, very good. So
keep with it, adjudicator, keep with it. It's all there.
So David Fernando first up.
Wow.
At 9:26.
And Ryan Kirstein, awesome Ryan. He'll be joining us very, very soon. Brilliant. Now, so let me just share screen one last time. So there we go. Ooh. That was the answer. So thank you to the panel members, and thank you to everybody for contributing to the case discussions and the submitters from around the world. Just one last thing, you guys have to please vote for the Golden Nugget winner, the person who's dropped the most wisdom and has been the most entertaining tonight, please. Oh, it's a tight race.
Can't I vote for Stephen? I'm allowed to vote. As long as you
You're
don't,
not allowed to vote. Hosts and
as long as the panelists don't vote for
vote.
yourself, like a certain American president.
I was just going to vote for Stephen as well.
Yes, there you are. I concur.
57% have voted. Go on, the rest of you, please do this final vote.
Your
Maybe
vote
the
matters.
football's still on. Is it still on?
Sorry?
Maybe the football is still on.
Yeah, maybe. Oh, a couple more. Okay, I'm going to stop it in 5, 4, 3, 2, 1. Oh, it's so close.
Ooh.
So, David, you're the winner of the Golden Nuggets Award. Well done.
Don't
say a
go
couple
to
of words?
Christmas. That's not fair.
You
That's
beat
very kind.
Stephen by 2.
Yeah, exactly. As in, it was all very close, and it's just a bit of luck. James, Rebecca, thank you very much for the invite. I've quite enjoyed things. It's been really, really useful. It's always great to listen to some other people when you go, I wonder if was I doing a bit out there? Oh, good. Thank goodness for that. Everyone else agrees, and we're all saying something remarkably similar and sensible. So it was really kind. Thank you very much for the invite.
Can we fit in one last question for Stephen from Anne Kennedy? Would an MSAP gastroc reach that lateral wound?
Yep. So actually, you can put it around the back of the popliteal fossa. I've put it up onto the distal third of the thigh on the lateral side of the thigh as well. So yeah, they can reach. They reach surprisingly far. Should try it at some point. You know, start with something simple. But when we're doing tumor work, sometimes the knee's coming out, and you can just pass it around the back. So it comes up onto the lateral side of the thigh, distal third.
I was lucky enough to work at ROH with Francis Peart. So Francis has been allowed to retire, was the West Midlands Finishing School. So I always pretend I'm still Francis's registrar. You'd be surprised at how much you can release. Always release the hood and the tendon on the proximal gastrocs like that. And the pedicles down here. So you can release him probably a couple of times. You can score him. He'll go a long way. And if you get the chance, go on a cadaver course and you can see it for yourself in safety. But if not, as Stephen said, go in stages. Use it as the workhorse in the simple case and see how fast it can go. You'd be surprised how far it drapes. You never want to pull it, but it drapes easily that far. I mean, you may not even have to be scoring it to fill the defect that was demonstrated by the Bogota team.
Thank you. Well, it's lovely to be here with our friends and colleagues from around the world. It's been a fantastic evening. I've learned plenty. I've really enjoyed it. We really appreciate all of our panelists for coming on. And your prize, David, will be announced, the prestigious Golden Nuggets prize.
And it's been a lot of fun. I had loads of fun. And just if people want to come to another one of these Countdown Plastics sessions, I don't know what the next topic will be. It'll all be announced on Twitter and on our website, www.stokemandevilleplastics.com. Good evening. Thank you very much.
Thank you, everyone, and good night.
Thank you, James. Thank you, Rebecca.
Thanks.